Welcome to ATCM, the Emergency Medicine Channel. A 21-year-old nursing student came to the ER with complaints of needle stick injury. On initial assessment, her airway was patent, breathing saturation was 99% in room air, respiratory rate was 18 per minute, circulation BP was 120 by 80, pulse rate was 88 per minute. Disability wise, GCS was full, and exposure wise, she was afebrile, and GRBS was 100 milligram per deciliter. She complained that she while closing the needle, like while putting the lid back on, she accidentally pricked the left index finger, the pulp of the left index finger. While we examined, there was no bleed and there was no abrasion as such, but she complains that while that happened, a little blood had come out. Then immediately, like after taking the history, we advised her to wash it with water and soap. After washing with water and soap, we inquired about her immunization status.
So how will we ask her to wash it?
Wash it with water and soap for at least.
So if a patient comes with needle stick injury, first step is to allow proper washing and allow, if it is bleeding, allow it to bleed. We can give a small squeeze, and if it is bleeding, let it bleed out. Okay. Then after that, ask her not to use any antiseptics or any chlorhexidine or something on top of it. Okay. So that should be avoided. Okay. And what in this history was, she got a needle stick injury while recapping. So what else should you ask in the history?
Whether actually the depth of the injury, to what extent it went, or is any injecting of any fluid was there or what.
So which all injuries are considered as high risk and low risk? So there are exposure to skin is there, exposure with blood is there, exposed with urine, feces, and also which all body fluids are high risk?
Blood or any body fluid which is contaminated with blood, example, be it cerebrospinal fluid, peritoneal fluid, pleural fluid, semen, be it vaginal secretion, that is considered to be high risk. And if with blood, it is high risk. Then other than feces, urine, then saliva, tears, they are considered to be low risk.
Low risk, okay. So that is one thing. So this is mostly blood, so it is considered as high risk. Okay. Then what other history you need to ask from it? This is the recipient. So this nursing student is the recipient. So what other history should you ask to the recipient?
Her immunization status, and also, ma'am, if she knows the source, like from where she got the prick, the immunization status and of the source.
Okay. Anything else? So everything is important. So regarding the recipient, so this nursing student, first we need to ask when this happened. Okay. So based on this only we can plan on giving post-exposure prophylaxis. So if it is more than 72 hours and all, we will have to anyway give HIV prophylaxis based on because it is delayed. So when did this happen? That is the first question. How did it happen? So was it during a procedure? So this was while recapping. So what procedure was happening? So any bone marrow aspiration or any vein puncture, or what procedure was happening? And how much, anyway, here the body fluid is blood. So how much amount got exposed? And what was the bore of the needle used? So if it was a wide bore with that is considered as more risk. And how much amount of blood was there? Was there any visible blood on that when she got pricked? So as these points comes in, that means it is high risk. That is regarding the exposure. And whether she was using any personal protective equipments. So these things should be asked. And before the patient presented to us, did she wash by herself? That also should be asked. So regarding when it happened, what was the procedure, any personal protective equipments were used, and what type of injury was it, what type of needle was there, any this amount of blood. That is one history. Then regarding the source, so does the patient know about the source? So that is important. So sometimes they might not be knowing what source it is. There might be some random needles, these things, and also what she know about the source. So regarding the source, we need to know whether the source is positive or not. Then what else we need to know?
If positive, then what drugs they are taking, any resistance to the drug, and the recent viral load to be checked.
Okay.
Then
Other than that, you need to know why that patient was admitted. So, if we don't know whether the patient's already serology status, if it is not done in the hospital, we need to know whether this patient is having end-stage liver diseases, or this patient is having any ongoing dialysis or these things. So, they might be exposed to this ongoing dialysis. Patients might be having different this dialysis machine they are getting exposed, or they are having any recent blood transfusion or any recent organ recipient and all. These are also, these history should be asked. So again, along with that, we need to ask the past history, any past history of any illnesses, or any sexual history, multiple sexual partners and all should be asked. Any IV drug abuser, these things should be asked with them, and their nationality also should be known. So that should be asked. Again, if it is a splash of blood to the eyes and all, we need to ask the recipient whether she was using any contact lens or anything. And another thing is that if it is a female who is a recipient, we need to ask their last menstrual period. So we need to know whether this individual is pregnant or not. So how much, so if we are getting a needle stick injury, how much is the chance of getting HIV, HBsAg, HIV, hepatitis B, hepatitis C?
HIV is 0.3%.
Okay.
Percutaneous transmission. And HPV is around, if the patient is positive, like if the source is positive, it is around 22 to 36%.
Okay.
If the source is not like unknown, it's like 1 to 6%
Okay.
transmission.
Okay. So mostly hepatitis B is having high risk of transmission. Then it is hepatitis
SBS antigen positive.
Hepatitis B is having more risk than HIV and hepatitis C. Okay, so that is a risk. So that should be known. And another thing is that we will have to, if this child is coming, this nursing student, they might be panicked at all. So we need to explain them the percentage, how much this is, and we need to ask whether washed or not, wash, and ask them to wash properly. Okay. Then after that, we will have to consider regarding the treatment. So treatment, then we will have to plan on asking the recent titer. So was this individual's titer known?
She did not test it.
Was she vaccinated?
Vaccinated.
Or
All 3
completed
doses.
the vaccine? Okay.
We did not check the titer.
Okay.
So,
And what did she know about the source? Did she know her source?
yes, ma'am. She knew the source, and he had his pre-op serology test was done in last November. It was negative.
Negative. Okay. Okay. So how will you proceed regarding this patient?
We will send the pre-op, like the HBs antigen, anti-HCV and HIV antibody of the source as well as of the patient, because we need the baseline. Because if she gets infected from this needle stick, it may come positive after 6 weeks.
Okay.
Also, since she doesn't know her titers, so we'll also test for her HBV titers, and where we have to see whether she was vaccine responsive or non-responsive.
Okay.
If the titers are more than 10, then she is a responder to the immunization that she received. If it's less than 10, then she would be categorized as non-responder but vaccinated. So, as of now, we sent her pre-op serology and also inquired about her last tetanus immunization. If she has been immunized within the last 5 years, then
So actually 5 years TT, if it is like a contaminated wound and all only, we will consider it as 5 years. If it is a very clean wound, 10 years is the TT. So if she was never vaccinated, then we will have to take. Otherwise, if the patient was vaccinated and since it is needle stick injury, mostly it will be clean wound. So if it is more than within 10 years, then no need to take TT. Okay. Regarding HIV and all.
HIV.
So hepatitis B. So suppose you told she might be a non-responder. So what will you do regarding a non-responder to hepatitis B vaccine?
Non-responder to hepatitis B, if a patient is positive, if patient is at the source is a known positive hepatitis B, then if patient is non-responder, then we can give hepatitis B immunoglobulin once, like one dose, and along with that, patient can be revaccinated.
There is no point in revaccinating because this patient, this individual, this student is non-responder. So if it is a non-responder, you will have to, if the patient is negative, nothing to be done. There is no point in vaccinating a non-responder. So if the patient, if the donor is positive, then we will have to give immunoglobulin first dose, and after 1 month asked to take the second dose of immunoglobulin because it is non-responder to the vaccine. So she will have to take first dose of immunoglobulin and second dose of immunoglobulin after 1 month. That is for a non-responder. And suppose if she is not vaccinated, what will you do?
And then immunoglobulin in the whole course of vaccination.
Vaccination if the patient is positive. If the patient is not positive,
Then
only vaccination. Only vaccination need to be done. Okay. Suppose this patient doesn't know her immunization status and all. What will you do?
We'll test for the immunization status, means whether she took vaccine.
Whether she took vaccine or not.
We will consider as non-vaccinated. And we can
First we'll have to check the titer. Titer. If the titer is low,
if less, then vaccination
And?
and immunoglobulin. And if titer is high, then
so vaccination and immunoglobulin. If the patient is positive, if the donor is positive, we will have to give the vaccine and also immunoglobulin 1 dose we will have to give. Okay, and she will have to complete her vaccination. If the donor is negative,
then only if the donor is negative, then only vaccination.
only vaccination is required, provided her this thing titer is low. Okay. The titer is normal, no need to do, no need to revaccinate. Okay. Regarding HIV,
HIV, post-exposure prophylaxis. Basically,
so when will you consider giving post-exposure prophylaxis in HIV?
If like the donor, we know that donor is HIV positive, like then we will consider giving HIV prophylaxis without even waiting for the test results. Or else if there is high suspicion of the donor being positive and there is percutaneous injury via needle stick, then also we can start post-exposure prophylaxis without waiting for the results. On the other hand, we can do a rapid HIV testing kit is there. We can do that and also send for HIV RNA for the confirmation. For post-exposure prophylaxis, it is ideal to start within 72 hours. But we can, even if patient comes after 72 hours, then also we can start. But it's better to start as early as possible.
Other indications for starting HIV prophylaxis. So HIV prophylaxis is for 28 days. For all individuals, we will not start HIV prophylaxis. When all will we start? If the source is known to be positive, we will have to. Then
like high risk.
If it is source is unknown also, we will have to start. Then if it is exposure is more than 72 hours, we will have to start. Then if the recipient is having any diseases like any liver, any renal diseases or any, if the recipient is immunocompromised also, we will have to start. Then if the recipient is pregnant or breastfeeding also, she will have to start on post-exposure prophylaxis for HIV. Okay. Then, what will you start?
Recommended with 3 antiviral regimen is there. So we have to start on tenofovir, emtricitabine, and either dolutegravir or raltegravir we can start.
Dose? Tenofovir
is 400 milligram.
300.
Only emtricitabine is 400 milligram.
200 milligram. Tenofovir 300, emtricitabine 200.
Dolutegravir is 50
mg.
And raltegravir is 400.
400 milligram. Once a day for 28 days. Okay. So suppose we are checking the baseline pre-op of the recipient and we find that she is HIV positive. So can it be because of this exposure?
Yes.
Very unlikely, because she didn't cross the window period and all. So if we are diagnosing her to be HIV positive, what will you do? Her serology is coming as positive, reactive. What will you do?
At her own P24 antigen.
First we will have to confirm. It can be false positive. So we will have to send for an ELISA. ELISA is what? ELISA, two types are there, qualitative and quantitative is there. So first we will have to send a qualitative testing to confirm it as positive. If it is confirmed to be positive, then we will have to check for the quantitative analysis. Quantitative analysis, mostly viral load PCR or qualitative analysis we will have to send. So we will understand the viral load of that individual. Okay. Then after that, based on that, we will have to see how much WBC, that means how much is the CD4 count. So based on CD4 count, we will have to start the antiretroviral therapy, and along with that, if at all she require cotrimoxazole, that also we will have to consider starting. So viral load, that quantitative testing will be done only once. So after the patient starts treatment and all, we won't be rechecking the viral load, because anyway after treatment the viral load will come down. So viral load will be checked only initially. Then what will you follow up if the patient is positive and started on ART? What will you follow up?
P24.
So only CD4 need to be checked. So already patient is proven positive. So after taking treatment, viral load will anyway come down. So now we need to see whether the patient's CD4 count is improving or not. So how frequently will you check CD4 count?
It's 6 weeks, 3 months and 6 months.
Ideally, yearly only you need to check, because CD4 per year only 100 CD4 count will increase. So yearly check for the CD4 count if the patient is a known HIV positive. So that is what we do. If either the donor or the source, if it's positive, that is how we do. So first we will confirm with ELISA, and that is qualitative. Then quantitative viral load we will be assessing. Then we will be checking the CD4 and starting on medicines. Then yearly CD4 checking only will be done. Okay. Then regarding hepatitis C.
Hepatitis C, there is no post-exposure prophylaxis as such. We have to consult like specialist for that. Other than that, we have to check for anti-HCV antibody as well as HCV RNA, and alanine transaminase can be checked.
If it is coming as positive, then we will have to check for the ELISA and rest of the things. Otherwise, we don't have any post-exposure prophylaxis for hepatitis C. So we will check the baseline now, and we will ask the individual to check after 1 month. 1 month, okay. That is how we do. Okay. So what else is there? Always make sure that if the titer is low and if you are planning for revaccination, always check the titer again, so to find out the individual is responder or not. Okay. Anything else? Nothing. Okay. Thank you.